case presentation about lung fibrosis. Pulmonary fibrosis is a condition in which lungs become scars over time. Symptoms include shortness of breath, dry cough, feeling tired, weight loss, and nail clubbing. Complications may include pulmonary hypertension, respiratory failure, pneumothorax, or lung cancer in developed stage. Pulmonary fibrosis is a scarred and thickness in the tissue around and between the air sacs alveoli in your lungs. This makes it more difficult for oxygen to pass into your bloodstream. The damage can be caused by many different factors, including long-term exposure to toxins, certain medical conditions, radiation therapy, or other medication and risk factors. Occupational and environmental factors is the most risk factor exposure to lung fibrosis. Long-term exposure to a number of toxins and pollutions can damage your lungs, like silica, alcohol, hard metal dust, coal dust, or grain dust. The radiation treatment can be other risk factor to be diagnosed with lung fibrosis. Some people who received radiation therapy for lung or breast cancer in women show signs of lung damage months or sometimes years after the initiation or the initial treatment. The severity of these radiation damage can depend on many factors like how much the lung was exposed to these radiations, a total amount of these radiations, and whether the chemotherapy was used with the radiation. Other risk factors can include age, sex, and smoking. Age. Although pulmonary fibrosis has been diagnosed in children and infants, the disorder is much more likely to affect middle-aged and older adults. Idiopathic pulmonary fibrosis is more likely to affect men than women. For smokers and former smokers, develop pulmonary fibrosis can be easier than people who have never smoked before. Also, pulmonary fibrosis can occur in patients with past history with respiratory disease like asthma, COPD, or emphysema. Of lung fibrosis, you can look for these videos to see the details procedure in the pathology of happening in the lung. The pathology of the idiopathic pulmonary fibrosis. It's believed to begin with injury to alveolar epithelial cells. The injury triggers repair response, including the release of prophy products and pro-inflammatory mediators. These materials, which leads to progressive fibrosis within the lung parenchyma and structure. The alveolar epithelium then becomes vulnerable to apoptosis, inducing further epithelial dysfunction as well as a distortion of lung architecture. These all materials will accumulate in the alveoli, which triggers the inflammation system in the body to work. These fibroses in the lungs and in the alveoli, which are traveling to the neighboring cells, and by the time alveoli will have a scars, will vulnerable can see in the X-ray image. These will affect the epithelial and the parenchyma of the alveoli, inducing the lung fibrosis.
Idiopathic pulmonary fibrosis, or IPF, is a life-threatening condition with a median survival time of 2 to 3 years from diagnosis. The pathophysiology of this condition is not fully understood, though it is believed to arise through successive injury to the alveolar epithelial cell compartment. Risk factors associated with IPF include age, infective agents, genetic predisposition, smoking, and other airborne irritants. Cytokines and other mediators released by a stimulated epithelium can promote aberrant wound healing, where the deposition and scarring process continues unabated. Fibroblasts and myofibroblasts play a central role in the deposition of extracellular matrix during this process, creating fibrotic tissue within the lung interstitium. Excess collagen deposition and the accumulation of myofibroblasts in response to injury distorts lung architecture and stiffens lung tissue, leading to impaired gas exchange, massively restricts the physical activity of a patient.
We have to discuss the lung fibrosis as a case presentation to represent our patient. Signs and symptoms: shortness of breath, which make our patient shortness of breath, dyspnea, fatigue, and cyanosis face, tachypneic, tachycardia, with difficult to speak a full words without take, a complete shallow and rapid breathing, with no obvious to any type of allergy to any food or medication. Patients come with lung fibrosis have to be assisted by nurse in vital signs measures. Here our patient have a 34 breath per minute, indicates a tachypnea. By assist chest rise and recoil, tachycardia by 110 per minute when she connected to the monitor. Also, the patient was hypertensive with 141 systolic on 89 diastolic when measured by sphygmanometer. Autosat was decreased to 85% by pulse oximetry. The patient EPG's test result was pH decreased to 7.33, indicates a blood acidosis. PaCO2 is increased until 51%. The normal range for CO2 in the blood is 35 until 45%, so that indicate a blood acidosis. Autosat is decreased to 84%, which indicate a mild dysphagia. HCO3 is a buffer, increase until 37.7, indicates that the buffer is trying to decrease the blood acidosis. Patient history. Most patients come with lung fibrosis come with a history of occupational working or X-ray exposure, radiation exposure. Here our patient have a history of patient from her husband that he described that his wife was working in the oil refinery company in the section where she may exposure to a dust from occupational and environmental factors. Long-term exposure to a number of toxins and pollutants and pollutions can damage her lungs. These include some toxic and chemical materials like silica. Also, she tended to smoke in ceremonies. To make a judgment that the patient have a lung fibrosis, we have to do this diagnosis. From some types of pulmonary fibrosis, the result from the CT scan can be very clear to make a judgment, but we have to do these 3 tests. You may need to test such as a CT scan of your lungs, which uses the X-ray to produce detailed image for your lungs. which can indicate the scars and the or abnormal clinical findings that we can find. Breathing and lung functions is also the second test we can do to measure how well your lungs are working and to assess the lung compliance. Also, blood tests in acidosis and ABGs exactly will show how your lung is. Here we have taken our patient as a sample. Lab test and chest X-ray for the infected alveoli, and it may develop into pneumothorax. From the lab test and chest X-ray, which show an obvious abnormal alveoli shape with scars in the lungs and shadowing over the X-ray image, this scars is known as a clinical finding reticulonodular opasitis, and it's an obvious sign to make a judgment that patient have a scars lungs with a fibrosis in the lungs. Some with the same signs and symptoms and respiratory distress or respiratory disease in general has a high threatening to be affected with myocardial infarction because they have the same classical signs and symptoms with dyspnea, vomiting, shortness of breath. Also, our patient has a high heart rate and a high blood pressure. But what makes the myocardial infarction ruled out that the patient auscultation by the stethoscope heard the sound S1 and S2 without any presence for the S3 or S4 or any abnormal sound like murmur. Also, the patient cardiac enzymes was in the normal level, the INR, the PT, the PTT. Also, the ECG ruled the myocardial infarction out because it was with normal ST segment straight without depression and elevation in lead 2, 3, V1, V2 conductive delay. Also, the P was rounded and before each QRS. QRS was normal but with a small distance near each other. The final result for the ECG was sinus tachycardia. So the myocardial infarction is ruled out. And here you can see on the ECG that the patient has P wave rounded before each QRS, a QRS with normal, delay, and T wave without elevation in the ST segment, elevation or depression, T wave in the normal range without abnormal height or depressed, which ruled out any doubt about myocardial infarction and give the final result of sinus tachycardia. These signs and symptoms, especially when patient was from the diabetes patient, the threatening was high that patient hyperglycemic state developed to DKA, to diabetes ketoacidosis, and that affect the respiratory state and cardiac state for patient. DKA has the same signs and symptoms with tachycardia, tachypnea, also with the acidosis in blood. But patient has no longer has a history of hyperglycemic state. Also, the patient was diabetes type 2 and the DKA is developed from the diabetes type 1. Also, the DKA has to have in patient a classical sign and symptoms with the polyphagia, polydipsia, polyuria, but our patient no longer has this type of sign and symptoms and easily to urinate. All vital signs that was taken from the patient was a normal blood pressure with 5.9 and 4.2 in accumulative blood sugars indicates normal blood sugars that rule out any threatening about diabetes ketoacidosis. الديفرنشال diagnosis كمان بيحتمل وجود الأزمة. الأزمة has the similar classical signs and symptoms with shortness of breath. بتخلي البيشنت ما يقدرش يحكي full words without take a complete breathing. بيكون في dyspnea، بيكون في fatigue، بيكون في نفس الكلاسيكال signs and symptoms، بس في إشي distinctive للأزمة إنه اللي هي البلسس بارادوكسس، بصير في decrease السيستوليك، بصير في decrease السيستوليك blood pressure لما البيشنت يعمل inspiration، وهاي الساينز ما كانتش موجودة في البيشنت with inspiration and expiration كان عنده the same blood pressure. also الأزمة هي الأزمة rarely إنها تكون both asthma and pulmonary edema، فالبيشنت كان معه past medical history من حيث pulmonary edema، فالهيستوري كان indicated أكثر لأنه البيشنت يروح على lung fibrosis. اللي عمل الرول اوت للأزمة بالنهاية اللي هو كان الإيفيدنس الأقوى الإكس راي، بناء على الديفرنشيشن between الريستركتيف والأوبستراكتيف ديزيز. الأزمة مرض بيأثر على الميكانيزم للريسبيراتوري بس ما بيأثر على الستركتشر وعلى البرانشيما، فالإكس راي بيّنت obvious damage في الألفيولاي وسكارز spreading على طول اللنجز، فكانت الرول اوت للأزمة وكانت الإثبات لللنج إنه البيشنت with lung fibrosis، لأنه الإكس راي بيّنت الفايبرز وبيّنت السكارينج الموجود على اللنجز، وبيّنت كمان الشادو اللي موجود على الإكس راي images which rule out the asthma threatening. Drugs and treatment. Like many respiratory diseases, lung fibrosis have a variety of drugs and treatment which can describe easily by the word O shit. O for oxygen, H for hydrocortisone, S for salbutamol, I for ipratropium, and T for theophylline. Hydrocortisone is a drugs with a class of glucocorticosteroids من أدوية الأنتي-inflammatory اللي بتعمل decrease الانفلاميشن، وبشكل عام هي من الاميونوسبريسنت drugs. الكوشن الوحيد لهاي drugs إنه بتعمل increase برضو كمان للجلوكوز من ناحية ثانية، فبده يكون كوشن وخصوصا للبيشنت diabetes. الميكانيزم اوف اكشن لهاي الدراجز الهيدروكورتيزون وادوية الجلوكوكورتيكوستيرويد بشكل عام اللي هي تعمل اميونوسبريسنت عن طريق البلوكيج للهستامين ريليز. الهستامين بيعمل استجابة الاميونيتي، فهو بيعمل بلوكيج على الهستامين، فبيساهم في انه يصير يقلل السيكريشن اللي بفرزها الجسم على البرونكيول، فبيعمل اوبننج للبرونكيول وبيعمل decrease للسويلينج والانفلاميشن. الدوز اللي هي 100 وبنعطى بالأغلب IV وبيكون diluted ب 2 ml normal saline. other drugs اللي هو السالبيوتامول من الأدوية اللي بتنعطى بالأغلب نيوبلايزر عشان البيشنت يقدر ياخدها عن طريق الانهاليشن. الكلاسيفيكيشن يعتبر برونكودايليتورز لأنه بيشتغل من حيث السمباثو اغونست على البيتا 2، فبيشتغل كبرونكودايليتورز. إبراتروبيوم من الأدوية اللي بيكون اللي هو اسمه البيوتيرول. باراسيتامول sympathetic antagonist بيكون هو blocking، بيعمل الباراسمباثيك anticholinergic فبيعمل برونكو دايليشن عن طريق انه بيعمل بلوكيج للماسكارينيك ريسبتورز، فبيعمل برونكو دايليشن وبنعطى ميكس في الاغلب مع السالبيوتامول في نفس النيوبلايزر. الدوز اللي هي 0.5 ملغ بالغالب. أغلب المرضى اللي بيكونوا بيعانوا من lung fibrosis بيكونوا برضو كمان بيكون عندهم history pulmonary edema مثل البيشنت اللي بنحكي عنه. فبنعطوا في الأغلب اللازكس اللي هو اللوب diuretics اللي بتشتغل على كلوب diuretics. بنعطي 2 أمبول، each أمبول فيها حكينا 20 ملغرام which decrease the pulmonary edema and increase the ability for patient to urinate. What I have learned from this case presentation حكينا اللي هي الريسك فاكتور ممكن تكون متعددة وفاريانت على اللنج ديزيز وتحديدا على اللنج فايبروسيس. حكينا اللي هي البوليوشن، التوكسيك ماتيريالز، الكيميكالز، الانفايرمنتال، والبيشنت هيستوري انه اذا كان هيفي سموكر او سموكر بشكل بالسيرمنز بس. فالسيليكا كان من احدى highly toxic materials which make your lung scarred and thickened your tissues, which make this abnormality in your alveoli prevent the normal exchange between your alveoli and circulation. This worsen progressively your breath, and it can be a difficult complicated with lung fibrosis. Pulmonary edema also can improve to a lung fibrosis if left untreated, like the patient that we wrote our case presentation about. Pulmonary edema أهملت فتحولت إلى اللي هي lung fibrosis لما تجمعت environmental والtoxic material، فاللنجز صارت inflamed وصار فيها السكارز وصارت lung fibrosis. Also lung fibrosis if left untreated that can make lungs more inflamed, which make a big risk of pneumothorax. Respiratory disease can have a contagious link to epidemiology or linked to inherited from family. respiratory disease ممكن حاجات تتنوع من حيث اللي هي الكوزز، ممكن يكون سببها epidemiology contagious or infectious disease أو inherited by family by generation. Respiratory disease has many similar symptoms but have to have a different healing and treatment, so don't mix drugs or take any medication without a specialized doctor's advice. And as we mentioned before, silica and toxic material can have a high variation to patient with lung disease. Also, shortness of breath can differ from morning to evening depending on the circadian cycle, which make the patient feel shortness of breath, especially in the morning. Here you can look for our resources that was taken from a scientific article and papers.